Good afternoon. Welcome to everyone for this week's endocrine grand rounds. We are very pleased to have Dr. Eyas Hattab, who is the A.J. Miller Endowed Professor and Chair of the Department of Pathology. He has been in Louisville since 2016. Prior to that, he was close by at IU. He graduated from medical school in Jordan, and then he came to the United States doing his pathology fellowship at the University of Florida, a neuropathology fellowship at Stanford, and a surgical pathology fellowship at Washington University in St. Louis. He then went to IU, where he stayed until 2016, and he moved here. Dr. Hattab is well known in the field of pathology and neuropathology. He has been an invited speaker at national and international conferences and has published over 100 peer-reviewed articles and many book chapters. We have all seen him, worked with him in our endocrine, neuroendocrine tumor conferences, and we are very glad that we will be learning something about pituitary tumors, which we often seem to focus on only their endocrine blood tests and things like that, not actually understanding the basic pathology. So we're glad to hear about it. Thank you.
Thank you very much for the kind introduction, and it's a pleasure to be among you. If you can, for those of you who are with us in a virtual setting, please do let us know if you can't hear me well. Again, I appreciate the invite, and my goal today is to try and go over general concepts of pituitary tumor classification. By virtue of their endocrinologic nature, we are going to focus on what we call adenomas, more or less, and try and really steer the discussion as to where are we today, and particularly in relationship to the 2017 WHO classification and what the future holds. Please feel free to interrupt me if I can be of assistance during the session. So I'm trying to advance here. Not sure that the advance button.
The cursor is actually inside.
Okay, so
here, let's do this. Make sure it's here. There we go.
Really?
There we go.
Okay.
The cursor was stuck up there, so.
Okay. All right. Sounds good. Well, it's never a good day if you don't learn something new, right? So I have nothing of interest financially or otherwise to disclose as related to this talk. Again, our goal today is to familiarize ourselves with the most up-to-date classification of pituitary tumors, particularly adenomas, and then understand how the 2017 classification came about. And then we are going to talk about the new nomenclature of pituitary adenomas or pituitary neuroendocrine tumors. We'll touch on a few non-neuroendocrine pituitary tumors just for the sake of completeness. And then we'll discuss the concept of grading adenomas or recognizing their aggressive behaviors and touch briefly on what has happened since 2017. So typically when we approach anterior or let's say pituitary tumors in general, we classify them as neuroendocrine and non-neuroendocrine. That's recognizing the fact that the majority of them are neuroendocrine tumors as represented by adenomas. So I would say that probably 95 to 98% of pituitary tumors in general belong to the pituitary adenoma category, and the others are rare or relatively infrequent. If you look at the incidence of pituitary tumors within the CNS, you'll find that greater than 16% of all pituitary tumors are pituitary adenomas, or almost all of them are pituitary adenomas. If you look at those benign brain tumors, then they occupy a larger majority. So they are the second most common after meningiomas. That is of relevance to our practice in pathology because this means that you won't always have an expert neuropathologist necessarily diagnosing your pituitary adenomas. These are fairly common that really most surgical pathologists will probably be diagnosing these, particularly in settings where there is not access to a neuropathologist. And for you as an endocrinologist or as a neurosurgeon or an oncologist, then there needs to be a continuous dialogue of what the overall approach to the management of pituitary tumors in a given organization. So historically speaking, the classification of pituitary adenomas has always been multidisciplinary. So we always refer to it as clinical pathologic. So it has dependent on a combination of clinical, radiographic, as well as pathologic features. Typically, most of these patients either present with endocrine dysfunction, a mass effect, and then they're followed by radiographic imaging, and some of the classification relates to the size and extension of those tumors. I will be focusing mostly on pathologic classification naturally. So in the past, before the era of immunohistochemistry or advanced molecular diagnostics, really pathologists had access to pretty much what we call hematoxylin and eosin stain. It's a stain that's a combination of blue and pink, and typically pathologists were pure morphologists, so would look at a glass slide and focus on pattern recognition and say, well, we think this is an adenoma by virtue of morphology, and then they would try and subclassify these according to the pattern of staining. So in an H&E, again, you're talking about shades of blue and pink, and so that's really how these terms came by. So when people said it's chromophobic, meaning it wasn't too blue, wasn't too pink, it was pale. When it was acidophilic, it was really pink. If it was basophilic, it was really blue. So those are fairly simplistic classifications that pathologists felt they had to do, and then they tried to see if there's a clinical connotation to these. So that's why even probably today you'll go to certain books and see, oh, this is a chromophobic adenoma. Well, great, but that's an unnecessary distinction. We no longer use those terminologies. It matters little what the color of those cells are today. So after that, there's been increased utilization of electron microscopy. I think if you go back to pathology literature in the 1960s particularly, you will see that there's been a great emphasis on using electron microscopy in the diagnosis of a multitude of tumors, not just brain or pituitary tumors, but they were fairly useful in the case of pituitary adenomas by virtue of the fact these are neuroendocrine tumors, and so these have secretory granules, and pathologists found, there is really a difference and maybe sometimes correlation with the number of granules that these tumors have. So whether they're sparsely or densely, and sometimes that's reflected on the endocrinologic behavior of these tumors. And so that's when the subcategories of sparsely and densely granulated were introduced in pituitary adenomas in general. And then in the early and mid the 1980s, that's when the era of immunohistochemistry came and revolutionized the field of pathology. So now we had a tool through which we were able to recognize cells by virtue of their antigenic nature. And so we were able to target certain receptors and find out a lot more about these tumors. And in the case of pituitary adenomas, that was pituitary hormones. So we have access to immunohistochemical stains for all of these 6 anterior pituitary hormones, and they at the time they revolutionized again the approach to diagnosing pituitary adenomas, and we were able to classify them accordingly. So if someone stained for ACTH, we call it ACTH secreting or producing adenoma. Those helped us a lot, but they were not foolproof, meaning, sometimes you were hostage to how well immunostains worked, and sometimes they just didn't work very well, or they were very difficult to interpret. But nevertheless, they were what we used until about 5 years ago. And so the 2004 WHO classification combined immunohistochemistry and electron microscopy, and if you go back and look at it, which this is the 2004 WHO classification of pituitary tumors, it had multiple categories. We'll go more depth into neuroendocrine tumors. That's what we'll focus our discussion today. But this is the 2004 terminology. Notice that it had terms that implied the immunohistochemical as well as the ultrastructural nature. So when we say densely granulated, that's really ultrastructure. Can we guesstimate or look at an immunostain and guess whether this is probably densely or sparsely? Yeah, we became better at it when we said, well, if a stain stains lightly, then this is probably sparsely. If it stains darkly, it's probably densely, by virtue of, again, having granules there and reflecting the staining nature of those granules. So we really stopped eventually doing ultrastructure on most of these and relied on surrogate immunohistochemistry. And ACTH reveals the fact that this was an immunohistochemical diagnosis. Now, what happened in 2017 is a shift from diagnosing or classifying pituitary adenomas based on their immunohistochemical expression into their lineage. So our understanding of pituitary adenomas was expanded by the fact that I'm gonna advance here, by the fact that we were able to understand their histogenesis much better and recognize that there are many transcription factors that influence the differentiation of a anterior pituitary cell. And there were three main transcription factors that were kind of gateway transcription factors that decided how those anterior pituitary cells differentiated, and that's TPIT, PIT1, and SF1. So each one of them gave way to a certain endpoint. So to TPIT to corticotroph, PIT1 to somatotroph, mammosomatotroph, and lactotroph, and thyrotroph, and then SF1 to gonadotroph. So what I'm summarizing here, and that's not 20147, that's 2017. I apologize for the typo here, but just showing you that the terminology has now been revised from one that combined immunohistochemical and ultrastructural terminology into a cell lineage type of terminology. So now we say it's somatotroph, it's lactotroph, thyrotroph, etc., referring to the lineage as opposed to the secretory nature. Why is that important? Because sometimes these show evidence of secretion and sometimes they do not, whether that's at the immunohistochemical or at the clinical function. And so the 2017 came up with several changes. One of them was the lineage-derived classification, but we also changed the way we grade adenomas. So if you recall, we had an atypical category. We now have abandoned the atypical designation, largely because it was highly irreproducible, and the behavior did not really predict necessarily the nature of these quote-unquote atypical category, and hence they were scrapped. We used to recognize that about half or so of adenomas are null cell adenomas. Where did that designation come from? From the recognition that about half, give or take, of historical pituitary adenomas did not stain for one of the 6 pituitary immunostains. Remember, about a few minutes ago, I cited some of the limitations for those immunohistochemical markers. Now, we recognize that most of those so-called null cell adenomas can be reclassified into one of those lineages, and they're not truly null cell. The fact that greater than 99% of what we used to call null cell adenoma now can be easily classified into one of the 3 lineages. Now, I think scrapping an atypical designation doesn't all of a sudden remove the fact that about 10% or so of adenomas behave more aggressively. So we recognize that probably 90% of pituitary adenomas behave in a fairly benign fashion. Roughly about half of them will require surgical intervention. Others they just require follow-up. And those that the majority of those that require surgical intervention do well, but then, like I said, about 10% or so recur. So the challenge here is how do we identify those? And that's when the term aggressive behavior was adopted, and mostly focused on recognizing historical entities that behaved more aggressively. There's been a new entity introduced, pituitary blastoma. We won't get into that today. And so the way the transcription factors discovery influenced our classification is that, again, those are key transcription factors that led to the identification of those 3 lineages: the PIT1, the SF1, and the TPIT, which I'm sure all of you by now are very familiar with. And that the recognition that further classification can be enhanced by additional pituitary hormones, ultrastructure, or other immunohistochemical tumors. So how did our terminology change? Not to be repetitive here, but I think that's part of the takeaways that we want, is that, please avoid the terms like ACTH, prolactin, secreting, etc. Let's stick to lineage-defined terminologies, and that's why this is now we call this lactotroph adenoma, meaning it's derived from the PIT1 lineage, and it secretes prolactin. Whether it's functional or not, it's still a lactotroph adenoma. Gonadotroph, same. We imply that they're derived from the SF1 lineage, whether or not they demonstrate clinical manifestations of gonadotroph adenomas, or they secrete FSH or LH or STIN for those markers. Again, I would highlight that the vast majority of null cell adenomas do stain for SF1, declaring a gonadotroph lineage. And so if you were to guess, you would have a 99% accuracy with guessing that null cell adenomas are gonadotroph adenomas. So, and that what gave way to the revised 2017 WHO classification. And what you have on the right hand side, the adenoma type, are the subtypes of what PIT1 lineage or acidophilic lineage looks like. So as pathologists, when we have an adenoma, how do we go about making the diagnosis and further classification? Well, I can tell you that the most efficient, economical way of diagnosing a pituitary adenoma or classifying it is, number one, you need to make morphology guide you somewhere. So you need to examine this and say, well, am I pretty certain this is a pituitary adenoma? And so that would rely on the pathologist's skills. There are markers that can help you deciding whether this is an adenoma or not, or a neuroendocrine tumor or not, if you're unsure. But once you make that assessment, then apply the three transcription factors, and that the yield among those is almost 100% that they will stain for one of the three markers. Now, if you have an SF1 positive adenoma, then you can comfortably make the diagnosis of gonadotroph adenoma next case. You really do not need to subtype that any further. If we have a TPID positive adenoma, or in essence a corticotroph adenoma, then you do want to go ahead and try and classify it into sparsely or densely, and we do that by employing ACTH immunohistochemistry and a low molecular weight keratin, and that's what this example illustrates here. If you have a PIT1 positive one, then you will need to employ anterior pituitary tumor or anterior pituitary hormone immunohistochemistry. Why? Because you probably do want to stop at saying this is a PIT1 lineage adenoma. You could, if that's not of significance, but typically you do want to determine what the sublineage is, and whether it's plurihormonal or not. Okay. Today, as I mentioned earlier, ultrastructure is rarely needed or required. So again, just flashing to you that within a certain lineage, there are multiple subtypes of adenomas, and that's really what this table highlights, particularly with the PIT1. And so the PIT1 positive adenomas are the ones that require more of our time and effort to make those classifications. Here is an example of an adenoma that on touch prep shows these plasmacytoid-like epithelial cells, that they are discohesive, meaning they're not grouping, and they have the nuclei pushed to one side. But notice there are these bright eosinophilic inclusions. We call these fibrous bodies, and actually the identification of this is histologically helpful even intraoperatively, because these are heavily associated with what we call somatotroph adenoma, sparsely granulated. This is one of those few settings where actually we still can make this diagnosis with high precision just based on morphology and predict with high degree of confidence what the subtype or what the immunophenotype is going to be. These fibrous bodies that I've just described to you stain strongly with count 5.2, which is an epithelial marker, and it's an intermediate low-weight molecular keratin, and those are the round bodies that vary in size. So in a corticotroph or TPIT positive adenoma, you typically expect to have one of these subcategories. And again, so how do we make that designation? By employing ACTH and cytokeratin stain. And in a case like this, really the important finding here is this pattern of concentric CAM5.2 immunostaining in tumor cells, as well as in, I don't have an image of it, in non-tumor cells. And those what we call like Crox-Hyland change. And so this is an example of what we would characterize as Crox cell adenoma. In the absence of these, if this is, as you can see, kind of a pale staining ACTH, then this would be a sparsely granulated corticotroph adenoma. That would be our diagnosis. In gonadotroph lineage, that remains one of the most straightforward workups, because again, if we can demonstrate that this has the SF1 lineage, then we call it gonadotroph adenoma next case. And this is a nice example of what gonadotroph adenoma looks like. Again, these very uniform plasmacytoid cells, they don't really have any of those inclusions I showed you earlier. On histology, you can see that they're just sheets of epithelioid cells. They have these pseudoglandular spaces on higher power. Again, very uniform, no atypia, no mitotic activity. This shows you the reticulin pattern, which only really highlights blood vessels. It doesn't show you the kind of nested pattern that we expect to see with anterior pituitary gland tissue, the non-tumor tissue. This illustrates to the limitations of immunohistochemistry. So in the past, when we did not have access to SF1, we would have an adenoma like this, where LH is only staining smattering of cells. And that's really a hard exercise to go through, because, is that significant or not? And I can tell you, if you were to call every immunostain that had, those scattered cells staining for LH as gonadotroph adenoma, you're going to overcall gonadotroph adenomas. You're going to overcall ACTH, growth hormone, and others. So that's when kind of the pathologist's hand was somewhat paralyzed by the interpretation of these. Now, the advantage of transcription factors is that these are nuclear markers. They are, as you can see, they demonstrate strong nuclear immunoreactivity. This is either all or none. If you have a few cells staining, that's insignificant, and you probably need to look at the reliability of your immunohistochemistry laboratory. So this is again an example of a gonadotroph adenoma. In that case, it was silent. The WHO 2017 did not completely get rid of the null cell adenoma category, recognizing that at the end of the day there may be a few adenomas that we may not be able to classify. However, those remain exceedingly rare. I can tell you that since the identification of those transcription markers, and we adopted them in the lab about 5-6 years ago, we have not identified a single case that failed to stain with a transcription factor. If you come across one that doesn't, the first order of business is this truly a pituitary adenoma or not? That's I think what you should ask yourself. So I think we've addressed null cell adenomas adequately. Let's talk about atypical adenomas or grading in general. So we talked about 2004, where we had the garden variety adenoma, the atypical adenoma, and the carcinoma, which is very rare. And in the past, how did we diagnose atypical adenoma? Well, it was really up to the pathologist to look at it and say, well, I'm not sure I like the appearance of these. There's either atypical, have too many mitosis, have high MIB1, and then we used P53 to kind of aid in it and say, well, if it has significant P53 staining, then that was probably atypical. It was not reproducible from one pathologist to another. And then it really did not do what it was supposed to do, which is predict long-term behavior. So, and again, these are some of the diagnostic criteria we used to adopt back then. This concept has largely been replaced by the term aggressive adenomas to acknowledge that there is a clinically defined group that will behave different, and those are about, again, 10% of adenomas, and the definition varies. So some are large, invasive, rapidly growing. Some of them you can look at the MRI imaging and say, well, I don't really care what the pathology says or looks on this. This is clinically aggressive. So that's why I think determining what an aggressive adenoma is not simply a pathologic diagnosis. This is more of a clinical pathologic diagnosis that should incorporate imaging as well as intraoperative finding. Even with that, there are tumors that will recur no matter what, and those again can be designated aggressive. And some are resistant to other means of treatment in addition to surgery, which is radiation or hormonal or immunotherapies or other oncologic therapies. So the term of aggressive and invasive have been historically used interchangeably, although the terminology is moving toward adopting the aggressive term just because it's a bit more inclusive, as opposed to taking an invasive, which may just mean that this is only radiographic or intraoperative finding. So again, this is to illustrate that the atypical adenoma has been abandoned, and now we replaced it with the recognition that some adenomas do behave aggressively just by nature of their subtype, and that some clinical and radiologic findings are important factors of that determination. So what if we as pathologists see an adenoma that's highly atypical by virtue of pathologic examination, is mitotically very active, has high proliferative rate, and yet there's no evidence of metastasis? We can't call it carcinoma. This is where I think most of us resort to a descriptive diagnosis, and so we would do the same, classify it, and say this belongs to what lineage, and say that put a note and say that this has elevated mitotic activity or elevated proliferative activity. Use this to communicate that information one way or another. So the 2017 recognized what we call special types, or ones with a more aggressive behavior and included these 5 subcategories in that category. Now, what has happened since 2017? Well, there's been a call to change the word adenoma into more of a pituitary neuroendocrine tumor. Why is that? That's because of the long-time recognition that we know that anterior pituitary is a gland. It's a neuroendocrine, has a neuroendocrine function, and that the more we know about adenomas, the more we see that they have a continuum in terms of their biologic behavior. So on one hand, many of them, most of them are benign, and on another hand, a few are have the metastatic ability, and we call them carcinomas. And then in the middle, there is a group that behaves more aggressively clinically by virtue of recurrence. And so that behavior is similar to other neuroendocrine organs. And so the thought process been here is that pituitary, anterior pituitary is part of this continuum. And you know that the same terminology we use elsewhere should probably be adopted. And so that's when the terminology of pituitary neuroendocrine tumors was adopted. It was introduced in 2017 and then later recommended to be used. So now, typically, if you want to make a diagnosis, you do want to replace your adenoma with pituitary neuroendocrine tumor. Why is that? Again, that's a direct acknowledgement that, you know, this may not be completely benign, even though we acknowledge that most of them will behave like what an adenoma would be expected to. It's not typical of an adenoma in another organ or so to recur or behave in a highly aggressive fashion. Now, this has not been without controversy. If you follow the literature, the Endocrine Society has objected to this designation. Why is that? Because they, in their view, they say, well, you know, the vast majority of these are benign. This is confusing. Again, that's probably a political controversy that's likely to be settled. There is, I think, a good reason behind keeping an open mind with pituitary adenomas and expanding our understanding of them and recognizing that, you know, our approach should not be so simplistic to assume that they're going to be as benign as an adenoma would behave. So some have adopted the 2017 and tried to simplify it. So this is the European pituitary group that proposed even further simplifying the pituitary neuroendocrine tumors into these categories, which are really, again, lineage derived. And if you notice, they just simply have taken out the acidophil adenomas, the croxile, and said, well, those are morphologic variants. It's just to stick with the more common ones and keep this as simple as possible. There's also a call to standardize our pathology reports, and I do think there's value to that. Why is that? Because we do this for most carcinomas. We do this for all other brain tumors that are not benign. And this is an acknowledgement that pituitary adenomas or pituitary neuroendocrine tumors, PITNETs, aren't really as simple to predict their behavior. And this is an attempt to try and gather as much information about them in one place so that it could help us with the management approach in these. So let's take a couple of minutes and discuss what has happened at the molecular level. If you follow brain tumors in general, brain tumors are far more advanced than other system organs, and the fact that we employed molecular genetics early on, and our understanding of brain tumors now is highly dependent on their molecular nature. We're not there to completely influence their behavior yet and have all the targeted therapies there, but that's usually the foundational work that eventually leads to the identification of biomarkers and targeted therapies. So let's talk about what's happened, some of what has happened since 2017. So every time you come up with new classification, now with the molecular tools that we have the ability to validate those data sets. So a new classification provides you with an opportunity for a new data set. And so if you do an unbiased DNA methylation hierarchical classification, like this paper did, this produced 3 distinct groups. And those 3 distinct groups aligned with the 3 distinct groups that the lineage-derived classification of the WHO adopted. So this is a good validation that this classification, at least for now, withstands the molecular test. Further testing of taking again, unbiased hierarchical classification of pan-genomic markers. So this is, you're pooling multiple molecular methodologies, and saying, well, let's do one based on histology or the 2017 lineage classification. So that's what it would look like. And on the right-hand side, this is, again, unbiased hierarchical classification based on pangenomic molecular findings. They're nearly identical, and that tells you again that these categories are indeed how these tumors should be classified. So that makes your pathologic classification meaningful at the molecular level, and hopefully at the outcome level, which is the next step. Now, this has not been 100% concordance, but note that what people call null cell adenomas, which is a very small fraction, is clustering with gonadotroph adenoma, and so this has again solidified the call to do away with null cell adenoma and say this is there's no such. All of these are gonadotroph, whether they stain for SF1 or not. So obviously I won't go into every biomarker, but to say that once you have reproducible data sets and reliable ones, then you are able to interrogate these further. And the idea of interrogating reliable classification data sets is the identification of certain biomarkers and genetic alterations that you can either use to develop targeted therapies or prognosticate and say, this is a marker of that will help us predict outcome. So those are very valid outcomes of this enhanced classification. And now, the next step is sorting through all of these biomarkers. And so in essence, this classification allows us to give better molecular profiling, biomarker and targetable discoveries and progression prediction, but it will require clinical, pathologic, molecular integration. And so the recognition that pituitary neuroendocrine tumors can have, at least 10% of them can have an aggressive behavior that will require additional management other than surgery, has called for that renaming of them as such, as PITNETs. And why? Because ultimately, those 10% of cases will require shifting the mindset toward a neuro-oncologic-like approach. That's really, if there is a take-home message behind this, is that, let's think of these as entities that can benefit from our neuro-oncologic approach. So in the next couple of minutes, I'm going to go into just a summary of what non-neuroendocrine tumors in the anterior in the pituitary do we have, and what we do with those at the pathologic level. So we now recognize three groups or three quote-unquote entities that we group into one: pituitary-cytoma, granular cell tumor, spindle cell oncocytoma, and there's a new WHO classification for CNS tumors. We call it CNS5 because it's the 5th edition. This is still in print. It hasn't come out. It should come out in the next couple of months. But now in the new classification system, these are now grouped into one quote unquote subtype or entity. So we actually group them as pituitary-cytoma, granular cell tumor, and spindle cell oncocytoma. We consider these probably as morphologic variants. In the past, if you looked at the 2016 classification or so, these were recognized as separate entities. We increasingly recognize that these, while they look a little different, their immunohistochemical nature, their molecular features seem to be similar. These are, again, unlike adenomas, these are infrequent, so we don't really have as many data sets of these as we do with pituitary adenomas. And they have a relatively similar clinical and radiographic appearance. The one other terminology that was proposed for these is TTF1 lineage tumors for pituitary, posterior pituitary. Recognize that these have to, by definition, stand for TTF1 transcription factors to be called as one of these tumors. This is just an illustration of the fact that most of these stand for TTF1, and then, yes, do they vary in appearance? Yes, this is more spindled. This has, as you can see, a lot more cytoplasm, so the tumor cell nuclei seem to be much farther apart from each other. And these, they have a finely vacuolated cytoplasm, and it has this kind of storiform pattern occasionally. But again, the unifying factors, TTF1. Evidence suggests that probably in the future, we won't even have to classify them as pituitary-cytomas, granular cell tumor, or spindle cell oncocytoma. We probably would just use one defining or unifying terminology for these. And so my takeaway points here that I hope I was successful in communicating to you is that adenoma classification is lineage-driven today, and that's been much more simplistic than any other classification we've adopted in the past. It's highly reproducible, and it's been validated by molecular data sets. PITNET's nomenclature, while not free of controversy, I think is better at communicating the potential biologic behavior of what we recognized previously as pituitary adenomas. It's just an acknowledgement of the limitations of that term. And that enhanced molecular profiling and biomarker discovery will allow for better management and outcome prediction. Hopefully that's really what we intend to do is give better management to our patient. And then the recognition that increasingly PITNET's management is shifting toward more of a neuro-oncologic-like approach. Again, that's not the case for 90% of these cases, but it is important to recognize that about 10% or so of our patients will require. So this is all I have, and I appreciate your attention. So I'm happy to take any questions if you have any. Thank you. Okay, I'm going to see. Are the single nucleotide genetic polymorphisms known? I'm not sure exactly what you mean by that. Do you mind elaborating?
Well, that depends on the whether the origin is genetic and of these pituitary adenomas, and if so, those transcription factors may have single nucleotide polymorphism that will result in that.
Yeah. I think okay. I think I know what you're getting into here. You know, that's the limitations of using transcription factors, right? But I think the exercise of getting to these three transcription factors that we currently use was an educated one. And I think it works well for SF1. It works reasonably well for TPIT1. But I think the polymorphism really comes into play when we are dealing with PIT1 transcription factor positive or lineage tumors. So there is a definite polymorphism within that particular lineage, and I do believe that with understanding PIT1 lineage tumors better in the future, we will have additional transcription factors that will allow us to further subtype these and parse out that polymorphism, as you put it.
Thank you.
Sure. Another question, getting biopsies from pituitary adenomas must be quite tricky indeed. How are biopsies obtained before surgical removal and for staging after surgical removal? Well, you know, I think it's important to recognize that surgical intervention is not always needed for pituitary adenomas. And again, I'm a pathologist, so I'm gonna let neurosurgeons and endocrinologists speak more intelligently about that than I can. But I would generalize by saying that roughly about half of these or so do not require surgical intervention, and that they're only biopsied if there is a question about their clinical or radiographic diagnosis, which with today's radiographic advances and endocrinologic advances, we are able to diagnose the vast majority of these. But I would yield to any of my colleagues to provide a better answer.
You're right. They're only interested in data comes from those that need surgery.
Right. Excellent. Any other questions I can help with?
Yeah, hi, Eyas.
Okay, Dr. Winners. Good to see you. Please go ahead.
So hi, Steve Winters here from Sarasota, Florida. Nice to enjoy your talk. It's very current, and thanks for with all the effort to put this all together. One of the slides showed the amount of methylation of the tumor, right? It showed that sort of heat map.
Yes.
I wonder if you could go back the slide. I suspect most of the doctors don't understand those graphs.
Well, I was okay. Let me go back to sharing my screen here. Where's the share?
Right next to that.
Where is it? Where's I don't see the share icon. Am I missing it? Is that the share?
Yeah.
Yeah. Thanks. Okay. Cool. All right. Excellent. Well, so it's I had so many other graphs, but I think what Dr. Winters is asking is, how does methylation cluster entities? This is, and what does unbiased mean? So, unbiased or unsupervised, that's probably a more commonly, is that you run methylation assays, which really kind of, you think about it as so many data sets or inputs. So do you see these lines here? These lines, each one of these lines, both include so these lines here and these lines here. So these lines include genetic alterations, and these kind of vertical lines here represent individual tumors. And so this is a computer-based program that clusters these based on their similarities and dissimilarities. And so you can see the reason they're called heat maps is that, again, we're kind of color matching, so we get these colors. And then you see that, one is almost entirely blue, one isn't almost entirely red, and some are a little more variable, but they have key alterations that are in common, and that's how this unsupervised hierarchical clustering is done. The supervised one, on the other hand, is if you take, we'll say, I'm only going to have the PIT1 lineage in this group, and I'm gonna have the SF1 lineage and then the TPIT lineage, and then I'm gonna run a supervised or a specific analysis on them and see if they look similar or not. So that would be kind of the different way of doing that. I hope I didn't fail you, Dr. Winters, in my explanation here.
Okay, well, that's the best you can do. That's how, you could ask all the doctors there how many understand this approach, and then you'll know.
Is that clear? Okay, there are some who are nodding, so I'll take it. All
right.
Okay.
Thank you very much.
Thank you. Yeah, I would. Yeah, and I generally, these aren't the settings that you wanna just blind people with these, but I do. It takes a while, but they do make sense. And my message to you: don't be intimidated by these. These are actually easy to understand if you kind of put some effort into it, and you're going to be seeing this more and more in other organ systems. Okay, you had a question.
Yes. So yeah, that was a great review. Thank you. Especially we have a lot of both questions related to the lineage and everything, and I know our junior faculty just did a lot of both. So my question was in relation to the prolactinoma. So this is more of a clinical question. So if you're able to help us with this, is we do have certain tumors where you treat them, the prolactin levels come down, and the tumor appropriately decreases in size. But then the other times your prolactin level does come down, but the tumor then changed in size. And of course, like you mentioned earlier, we don't do biopsy like we do thyroid data. So is there any other way of how do you explain it?
Yeah, so for those of you who are attending virtually, the question is when is given the example of a prolactinoma, that's one that's responding to therapy and shrinking, and one that's not responding to therapy, and particularly when it's not biopsied, if there is a zero approach. Obviously, we as pathologists work off of tissues. So there's probably very little information I can provide you without access to a tissue. Having said that, I want to remind you of what we call now liquid biopsy, okay? And which is, a recognition that, blood-based testing for biomarkers that we identify in tumors may be helpful without that traumatic surgical intervention, particularly in a highly sensitive anatomical site like the pituitary cells. And so, but I would say that for us to get there, it's enhancing our understanding of the biomarkers that these tumors have. So now that we are about 4 years into our enhanced classification of pituitary adenomas, I think our hope is that, if we recognize biomarkers that can be accessed in a liquid format, would be a promising factor. Short of that, today, I think that's why you will see occasionally attempts to biopsy. If again, I think if that's based on a single case approach. So if the patient is asymptomatic, probably no one would touch it. But if it's symptomatic, and then yes, some intervention is needed. Well, thank you all. I appreciate your time and attention, and I hope you benefit one way or another from this. So thank you again.